All right, so WBCs. So we mentioned that RBCs and platelets derive from the stem cell, and the stem cell for the white blood cells can also differentiate down different paths, right? So those at the stem cell, we could differentiate down this path or this path, and they can then further get all the way down to the white blood cells that we see inside the blood. And those white blood cells are never let monkeys eat bananas, right? So that's a never. You get N, never, right, for neutrophils, which are the most popular. You got lymphocytes, which are next popular. You got monocytes, which are macrophages also. Also, monocytes are in the witness protection program. And whenever they're in a different tissue, they're called something different. So if a monocyte's inside the skin, it's called a Langerhans cell. If it's in the brain, it's called a glial cell. If it's in the lungs, it's called a dendritic cell. If it's in the liver, it's called a Kupffer cell. I don't think you should say it's a monocyte. Anyways, eosinophils, because it's hematology. They would like to confuse you. So eosinophils are next in line, and then we got basophils, right? So some of these you may have heard in the past, like eosinophils are for allergies, right? But neutrophils, that's primarily bacterial infection. You're going to see those rise when you have a bacterial infection. Okay, so we're going to talk about leukemias, right? So leukemias and lymphomas and multiple myeloma. These are all blood cancers. These are all overproduction of white blood cells of some fashion. And we want to separate them down the middle here for what are lymphocytes, right? And what are not lymphocytes, basically, or granulocytes, technically. All right, so the lymphocytes are your ones that are sit in your lymph nodes, right? Your spleen and your lymph nodes, the axilla, the neck, the inguinal areas. That's where when they're the mature ones, that's where they sit, right? And they're there to fight off infection, right? So you can have the mature adult ones overproduce, right? You're producing way too many plasma cells, for instance, right? That's technically called multiple myeloma, where your plasma cells are going crazy, making way too many of themselves and making way too many what? What do plasma cells make? B plasma cells, what do they make? They make antibodies, right? So our B cells are incredibly high, and also are, it's really the B cells the thing they produce is going to be actually high that we measure for multiple myeloma, and the thing they produce are antibodies, right? So we have CLL, or chronic lymphocytic leukemia. Usually the chronic ones being we're at the bottom half. We're in the adult or mature part of the white blood cell tree here. So you can know CLL and CML. Well, CLL is chronic lymphocytic leukemia. So you have a lot of lymphocytes being produced. And they are these lymphocytes right here. And usually they actually aren't that functional. They actually start getting in the way, right? But CLL is too many lymphocytes, right? Too many B cells and T cells. And it's just way too many that it crowds the RBC production. So the RBCs shut down. It crowds the platelet production because the platelets shut down, right? And then what else? We got ALL, acute lymphocytic leukemia. So that's too much lymphocytes. So we're on the right-hand side over here. And we have acute usually means young, right? So we got acute over here and acute over here. So acute lymphoblastic or lymphocytic leukemia, that's where you have way too many immature. It's like you have like 10 8-year-olds driving grandma's car. Like, I know how to fight infection, right? No, you don't. All right, so these guys are high risk for infection, right? So ALL is too many lymphocytes, right? And then on the other side, is your granulocytes, or your never monkey eat banana, right? Those are all your other ones that we haven't talked about yet, right? So those ones are, you can have the adult ones in excess amounts, right? That's chronic, that's the adult one. And then we have too many of the young ones, the acute ones, right? So acute myelogenous or chronic myelogenous leukemias. So that's how you interpret these guys, right? So let's take a look here. What's this?
All right, I have those test results right here for you guys. No more waiting. We're just going to play this audio file and we'll find out what you have.
You have stage 4 leukemia.
Here we live. Make it count.
we'll do WBC overview, and then we'll take a break because the next slide is leukemia. All right, so white blood cells. So you can do a differential, right? We talked about that's the fancy one. That's where you pay the deluxe package for free parking. Where's my cursor at? Lost it. All right, so CBC with differential, because you don't always need to do a differential to figure out everything is going wrong, right? Usually it's just a plain CBC that gets your H&H, it gets your white blood cell count, it gets your platelet count on there. Where's my platelet at? Platelet. There it is, the bottom. And then everything else is the white blood cells, right? If we want a differential, we want to know what the neutrophil count is, what the lymphocyte count is, what the monocyte count is, what the eosinophil count, right? It's never let monkeys eat bananas, right? So WBCs, again, they come from that stem cell, and there's different factors that will stimulate it to produce the different pieces of the white blood cells, right? Remember interleukins from an inflammatory response? That tells it, oh shoot, we need to make more B cells and T cells. We need to make more white blood cells because there's an infection out there, right? There's inflammation happening. So when you have a surge response, right, you have increased white blood cells because in a surge response, you have all those chemotaxins and interleukins and cytokines that will stimulate the white blood cells to start differentiating, okay? And again, all of this is in the bone marrow. It's not until the adult forms, that's where they start going out and doing their duties, right? And what are their duties? So your neutrophils, those are bacterial. They're fighting bacteria out there. Your lymphocytes, those are your B cells and T cells. The B cells release what again? They could be plasma cells, and they release antibodies, right? Your T cells, helper T cells are one of them, but also we have natural killer T cells, and those are like bounty hunters, right? They go out and they find the exact antigen that they're looking for, right? And then, of course, the antigen that was presented to them originally was what the B cells made antibodies against, right? So where are these at? These are in bone marrow primarily, and they go to university, some of them. Some of them are college-born, and the college in the body is the thymus. All right, the thymus is where your T cells go to learn how to be a bounty hunter, okay? So thymus is T cell university. And then once they're done there, once they've graduated, they go back home to not the bone marrow, but now to the lymph nodes, right? They go to the lymph nodes, primarily, again, the neck, the axilla, and the inguinal area. And then, of course, the spleen being the biggest lymph node. And our B cells hang out there too. The B cells, once they're made in the bone marrow, they then go off the bloodstream and they make their way to a lymph node, right? There is a certain percentage of them just float in the bloodstream, and that's what these numbers down here are. And it's nice that the Never Let Monkeys Eat Bananas also lines up with our numbers. Has a nice pattern to it. Okay, so what else? So mature cells are our Never Let Monkeys Eat Bananas. Our neutrophils, lymphocytes, monocytes, eosinophils, and basophils, right? Bone marrow is where they start, and then they make their way to the blood, and some of them will then deposit in tissue, okay? Normal white count's 4 to 12K. As we know, if that's low or high, that could be the first step in what? In a surge response, right? And leukocytosis, that surge response happens with just a simple SNS response. You have white blood cells that are just sitting in wait along the borders of the vasculature. They're just all there like guerrilla warfare. They're waiting for a white blood cell to make its appearance, and they will, what is called, demarginate. They will come from the margins and go into the bloodstream, right? That's when you have like a trauma or you have like a SNS response, your white count goes up because they're just ready to attack, okay? And what else? So also, like, you might hear about left shift and right shift and up shift and bands. All that means is you can only go right. You can't go left, right? You're not an omni-turner when it comes to CBCs, right? So it's basically the textbooks in the 50s and 60s, right? They had limited printing capabilities. So when they printed this whole hierarchy here, they couldn't print it vertically. They could only print it horizontally. So as we mentioned with like erythrocytes, when you have erythrocytes that die, what's next in line that comes out is erythrocytes when the RBCs die. The next one is the reticulocytes that are called the war, right? So that count goes up. It goes to the right, right? Same thing with neutrophils. The neutrophils die, the young neutrophils come out, the bands. The reason why they're called bands, those are the young white blood cells. And it goes to you can see if you draw on its side, you have bandemia, which means you have a right shift when you have more and more young white blood cells coming out, right? It took me a long time to figure that out. I was like, why is there never a left shift? All right. So that's the idea behind white blood cells, right? So we're going to talk next about too many of the lymphocytes or too many of the granulocytes over here are neutrophils, eosinophils, and basophils. So you can see the bands here are the young neutrophils. All right, so let's take a break and come back for leukemia. All right, let's start back up. So we're finishing up white blood cells. All right, so these are all the white blood cell cancers, and we tried to give you a little framework on how leukemias work, right? They're usually either the top of the cascade or the bottom of the cascade. If at their bottom, they're usually chronic, right? If they're at the top, then you have usually young and immature white blood cells. They're trying to do the job of the adults, right? Those are your acute leukemias. Again, you can have acute lymphoblastic or acute myelogenous, right? The myelogenous cell line comes down to your everything except for the L's. Never let monkeys eat bananas, but no lets, right? So neutrophils, monocytes, eosinophils, and basophils. Okay, so we have acute and chronic. Usually chronic is slow moving, it's slow growing. It takes a while, usually it occurs in adulthood, whereas the acute ones usually occur in children. All right, usually, right? It's like acute lymphoblastic is most common in children, whereas AML is really popular for adults, 85%, right? So WBCs multiply uncontrollably, and they don't die. So they've turned off the kill switch, basically. All right, they keep cloning themselves, and they keep cloning, and they overcrowd the bone marrow, so the bone marrow can't do other things, right? They can't make RBCs, and they can't make platelets, okay? So we have way too many of these, and they don't undergo apoptosis. Apoptosis is the kill switch, right? Every cell has that. That's called programmed suicide. It's a suicide button, right? So this is an example of apoptosis. So it's okay, it's time to apoptose. Okay, right? And they go ahead and they apoptose themselves, right? So, but these guys have turned that off. They're like, nope, not gonna do it, right? So they just overgrow and overgrow and overgrow. So up here at the acute side, so maybe at the top of the cell, now we've come over, we have too many of these myeloid ones, right? So if it's acute myeloid leukemia, it's too many of the myeloid precursor cells that usually make our neutrophils, eosinophils, basophils, etc. We have way too many of them. And we have way too many of them and not any neutrophils, eosinophils, or basophils. So neutrophils are responsible for what? What do they usually do? Usually fight off what? Bacterial infections. So we're at risk for infection. That's usually the through line here. Every one of these is a risk for infection. Okay? So if it comes to the myeloid cells, not the L, but everything else, right? They get, you're going to have a high white blood cell count, but you're going to have a non-functional white blood cells, right? Sometimes it'll make its way to the bloodstream, sometimes it won't. We'll point out the particulars there. All right, so then lymphocytic, whether it be chronic or acute, is on the lymphocyte line. What are lymphocytes again? Those are your B cells or your T cells, right? B lymphocytes or T lymphocytes. Okay. All right, so what else? So we got, there's usually an unknown stimulus, but Down syndrome is the highest risk of developing CML. And as we'll find out, CML can turn into ALL or AML. So 90% of Down syndrome patients or population has this what's called a Philadelphia chromosome, right? And it's going to put them at high risk for developing CML, okay? And then what else? Benzene exposure, which is found in gasoline. Radiation exposure for cancer puts you at risk for blood cancer, ironically. Smoking, obviously. Alcohol might as well be up there. But family history puts you at risk for these white blood cell cancers, right? So the immature WBCs are produced, right? And they're either like a blast cell or a young cell, and they never really mature. And even the older ones, like when you have chronic ones, usually they are not functional, right? And there are some exceptions, which we'll point out. All right, so they never mature, and they are functionally immunodeficient, so they're a high risk for infection. They never undergo apoptosis, right? So they crowd the bone marrow, and since they crowd the bone marrow, your RBCs and your platelets are also going to be low. Okay, so you got young WBCs that are ineffective, right? So again, infection risk, we got anemia symptoms, we got thrombocytopenia symptoms. All right, so we're just adding all the stuff we just talked about. And then also, since you have so many cells, your spleen is going to try to break them apart, and that can cause more problems in and of itself. And also your what's called the reticuloendothelial system, the RES, is like a garbage system. It gets rid of the old and senescent cells and all the old stuff, like we talked about the macrophage as part of that situation, and that can cause splenomegaly and also liver to get big as well. Okay, lymphadenopathy, that's just a swollen lymph node, a lymph node that is swollen. That can happen in certain variations of leukemias, right? Usually the B cell, T cell ones. So yeah, so that's the idea. That's the overview of this, right? So we got these mutations due to sniffing glue. We got benzene exposure. All these things are putting us at risk for leukemias. And then we're at risk for, and then like I mentioned, CML is the one that it can convert to the other two leukemias. All right, so this is AML, acute myelogenous leukemia. All right, so no B cells or T cells, but everything else. All right, so Downs patients, they're high risk of converting to AML. They're high risk of converting to ALL. They usually start with CML. All right, this is the most common adult leukemia. About 85% of adults can develop it, and CLL is most common in adults overall, but acute lymphoblastic is the most common in kids, just to differentiate. Usually you think acute for kids, but it's the ALL that is attached to kids. All right. So it's acute rapid onset. So the acute diseases, like we mentioned, are fast. They happen all of a sudden. Not all of a sudden, but they happen quickly. And we have too many cells of a certain type, right? And these are our myelogenous cells. And specifically our stem cells, or are early in the white blood cell production line. We have way too many of those, and again, they're crowding. They're causing anemias. They're causing risk of infection because they don't know how to fight. They're not a grown-up neutrophil. They don't know how to fight that infection. Okay, they're gonna get bone pain because you're producing way too many cells in the bone marrow, and they get this bone pain associated with increased production. And just like when you have an immune response from like a viral infection, you get like malaise and you get night sweats and such. They get that as well. Weight loss, fever, chills, night sweats. All right, kind of like our TB patients and our patients with a viral infection. Okay, and as we'll kind of find out, this gets a name when we talk about lymphomas. So lymphomas and leukemias are similar, but they are different, and we'll point out that difference. Okay, so then high INR PTT is associated with DIC. This is the only one of our leukemias that actually triggers a DIC response. It can cause an inflammatory response, widespread, and can cause DIC as a complication. So like all leukemias down here, we have a summarizing table towards the end of the section, but it's just kind of putting a little preview on each slide. All right, so all leukemias are a risk for infection, right? And all leukemias usually will have leukocytosis, which is what? What's leukocytosis? It's way too many white blood cells, right? They're going to have anemia, thrombocytopenia, except there's one exception we'll point out, and they're at risk for bleeding and bruising, right, coming from the thrombocytopenia. All right, got mutations that are happening, and with AML, it has DIC as a unique finding that differentiates it from the other leukemias. And we'll talk about tumor lysis syndrome, and that has a particular set of symptoms and lab tests we look at, but we're producing all these extra cells. We're going to eventually destroy them. And when we destroy them, that's going to start causing the release of those cellular contents. And these cells, unfortunately, have nuclei, right? We broke down so many RBCs, they didn't have nuclei, right? But what's inside of a nuclei that's different from an RBC is DNA and RNA. And DNA and RNA, when they get broken down into uric acid. All right, so we'll point that out on the next slide. So uric acid is an acid, but also can cause kidney damage and cause all kinds of problems. Uric acid. Okay, so tumor lysis syndrome and DIC are complications of AML. Not alone just the bleeding, anemia, and infection risk, but this extra amount of cells will start crowding, causing bone pain, causing this excessive production. You're using all of this extra energy, so you get some weight loss. So you have this constant immune response, immune development, and that's going to cause the malaise and fever and such, night sweats. There are, again, we're trying to keep it as simple as possible because there are 8 different leukemias, and each one of those 8 leukemias has 4 to 8 subtypes. So it can get really ridiculous when we talk about leukemias. All right, so tumor lysis syndrome. So this is the complication of several of our leukemias, including which ones we just talked about? AML, right? So we're breaking open the cells here, right? It can happen with chemotherapy, but it can also happen with leukemias when our blood or when our spleen and such is rightfully so chewing on these extra cells that are not functional, right? So it has the same things that RBC hemolysis had, where it has a LDH increase, but what else is inside there is phosphate is in there, and then phosphate is going to bind with the calcium in your bloodstream. So your phosphate and calcium are going to be, they're inverse. So the phosphate increases, that's spilled out of the blood cell. So phosphate increases, calcium goes down, LDH goes up, and uric acid. Uric acid is a byproduct of DNA and RNA breakdown, right? When we spill DNA and RNA in the bloodstream, you have enzymes that are going to break it down into uric acid. So that's all cool, but when you have too much uric acid, your kidneys can't tolerate it. Your kidneys get damaged directly by the uric acid, but also the uric acid itself forms nephropathies and nephrolithiasis or kidney stones, right? And those kidney stones will then block flow of the kidneys and cause more kidney damage. Okay. And also, what's inside every living cell in the body besides LDH? Potassium is inside the cell, right? So they can get hyperkalemic. That would be a feature of tumor lysis syndromes. There's a complication that happens with leukemias and also chemotherapy. This is usually where you see this emergency. And then so again, phosphate is elevated, which makes your calcium low. LDH is up. DNA, RNA, you can't measure DNA, RNA, but it can get broken down so fast into uric acid, which starts causing damage to the kidneys. K will be elevated. And when we talk about musculoskeletal next week, these guys are going to overlap, right? These medications you can also give for gout, right? These guys can develop gout too, but gout is with the elevated uric acid, and we give these 2 guys right here in an acute crisis. We give allopurinol and we give respiricase. Sounds like Rasputin, right? So respiricase and allopurinol, they're going to break down that uric acid into something that's not going to be damaging. Okay, so hyperuricemia causes all these problems with the kidneys, causing acute kidney injury, which can be detrimental to someone. All right, so we had AML, now we're doing CML. CML is too much of these lower cell lines down here towards the bottom, right? It's usually asymptomatic, but then it can start developing excessive amounts of cells, and the cells are not lymphocytes, B cells and T cells, they're everything else. And this is the only one that has thrombocytosis, which is too many platelets. So it's the only one that has too many platelets. So thrombocytosis is that's one of the differences between CML. It also has tumor lysis syndrome, just like what's called AML, but it actually turns into AML. Ironically, it can actually go back in time all the way up to the blast cells and convert itself into AML. That happens, what, 20% of the time, I think? Yeah, 20% every 1 year. If someone has CML, they have a 1 in 5 chance of going into AML. Okay, so they're at high risk again for tumor lysis syndrome or even DIC for that matter. It's called a blast crisis. Okay, so unique findings is the Philadelphia chromosome. That's not really something you're going to see on labs. That's just something that you're associated with it, but it's really that puts someone at risk. Someone with Downs usually has this risk factor. All right, therefore, someone with Downs has CML, 90% of them, and then they are high risk for a blast crisis or AML. Okay, they can also go into ALL. They can go all the way back, and they can then recycle this way or down the lymphoblast site. Okay, so blast crisis puts you at risk for tumor lysis syndrome. I should also add DIC for which one? AML has DIC attached to it, right? So this cell is just differentiating. Usually it's asymptomatic, but 20% each year, 20% chance of converting to an acute leukemia of either variety. Okay, so they have thrombocytosis, which is the unique finding for CML. Otherwise, everything's pretty much the same. They can have excessive breakdown of their cells and then cause what's the syndrome? Tumor lysis syndrome, right? They have the bone pain, they have the fever and night sweats, chills. It's all the same. They have anemia. You'd think they might have polycythemia, but they have anemia. All right, so ALL. So it is rare, but it's common in children. And there are 3 types with 11 types each. So we're not going to go into those at all. We're just going to talk about general ALL. All right. So you have young, non-functional lymphoblasts, where there's 2 different varieties for the stem cell up here. Right. You have the myeloblasts, which we had AML and CML. CML, ironically, can make AML and can make ALL. It can turn into either one. Okay. But lymphoblasts, they are, that's your white blood cells that are going to turn into B cells and T cells. But guess what? These guys are immature and young. They don't make B cells and T cells. They're pre-B cells, pre-T cells, and they don't differentiate. They're stuck there. Okay. So what else? So you get crowding, like we mentioned before, and they're going to get low platelets and low RBCs, and they are functionally infectious, right? What they call immunosuppressed. So they need to get they need to be at high risk for they're high risk for infection. Okay. Complications. We got so many of these cells, your body's gonna start breaking them down, and now you're at risk for tumor lysis syndrome again. Right. Same thing. Weight loss, night sweats, fever. Right. Because they're constantly making these white blood cells, and since they're constantly making the white blood cells, they get bone pain. Right. It's actually the worst bone pain compared to all the other leukemias. All right, they got the anemia symptoms, they got infection risk, especially a high risk infection because they can't make B cells and T cells. Remember, like HIV, that's like your neural network for your immune system. They don't have that. Okay, what else? So you guys have like some lymph node swelling because your T cells can also be in your thymus, and also younger ones might have made their way to lymph nodes. And here's our tumor lysis syndrome down here. All right, so CLL, so chronic lymphocytic leukemia. So we have too many mature lymphocytes, but you think they're mature, but they are actually not that functional. They're shooting blanks, all right? They're shooting out plasma cells, like, here's a plasma cell. No, that's not working, all right? It does not work against the infection you intended to, okay? They are not functional, right? They might be shooting like what's like an HBV antibody, but it's not going to be an effective antibody. Okay, so they got leukocytosis, which is an elevated white blood cell count. All right, and these guys usually have like a profound elevated white blood cell count, right? So greater than I'm thinking of the other one, next one. But these have a really high white blood cell count, just like our other leukemias. And again, that's going to overproliferate and push out the production of RBCs and platelets. Okay. Smudge cells is just something unique on the findings. When they do a biopsy and they look at the blood, they can see smudge cells. All right, but what else is unique about these guys? You guys have the these are usually asymptomatic. That's what I was trying to get to. These are like a 50% chance of just being asymptomatic. They don't really have a lot of symptoms, but it does not have a blast crisis, kind of like CML did. CML can convert to either leukemia. This one pretty much stays the same, and it's 50% of the time it's just no symptoms. When it does have symptoms, that's when you get the anemia, thrombocytopenia, and they get hypogammaglobulinemia. So they get low gamma globulins, right? Remember your IgGs, right? You're shooting IgGs out when you have an infection, and these guys just shoot blanks. They don't work good. Okay. So that's something they can look on diagnostic tests to see if they have low protein output. All right. Since the B cells and T cells don't work, your spleen doesn't work good. That means your spleen can't fire off and kill these different different bugs that have like a shell around them, have a membrane that our normal white blood cells can't get through. The spleen needs to be there to tag them so they can be taken out. All right, so general symptoms, lymphadenopathy, right? Especially the neck, axilla, groin, right? They got splenomegaly, especially CLL, because L is lymphocytic, right? That it has excessive amount of B cells and T cells. The spleen getting big. Where's your spleen out? On the left side or right side of your heart? Left side or right side of your body? The left side of your body. Therefore, when it gets bigger and bigger and bigger, you're not going to be able to. You're going to get early satiety, right? You're going to get satiated early. So you have early, and they can get abdominal pain as well. And then hepatomegaly, because you're constantly breaking down these excessive white blood cells, and then the liver can get big, the spleen can get big, because it's working overtime to process these things. The bone pain, especially your acute ones, where they're constantly producing these young white blood cells. Leukocytosis, right? They're spending energy left and right. That's why they have night sweats. They have the weight loss. They have the fever, and they got the increased immune response, which makes you feel like crap all the time. Okay. And then we could do what's called flow cytometry, where they take a sample of the blood and they throw it through a machine that looks at the shape of the white blood cell and identify whether it's a B cell or a T cell or a neutrophil or a blast cell. It knows based on the shape what it is. So they can identify and say, oh, you have so many of these blast cells, you have this leukemia. Okay. Anemia and thrombocytopenia we mentioned many times. Those are features of all of them except for which one? Of CML. Okay. And then bone marrow biopsy is something we can do to determine the exact cell type, because again, remember there's one with 3 types, 11 subtypes. You have to know exactly which type of leukemia they have, and then you can give the right therapy for them. Okay. And genetic testing can be done if they have chromosomal abnormalities or the like. All right, so the lymph node elevation or increase, lymphadenopathy, increased lymph node size, right? And the reticular endothelial system is what's breaking down all of your excessive white blood cells, and then that's going to be working overtime, and that's also going to get swollen. So here's our spleen getting swollen, causing abdominal pain, but also early satiety. All right, so leukemia treatment. What's the treatment for leukemia? So basically, it's not working. So we can try chemotherapy to get it into what's called remission, where you're putting here's all the white blood cells that we're looking at. We're trying to get the number of white blood cells or the production of that white blood cell below a certain amount, right? A certain amount of white blood cells, and that will then technically be remission. This doesn't work all the time. So it's not equal to a cure, because they could all of a sudden 1 year, 2 years, 3 years, 4 years later, they can all of a sudden have a crisis, right? Where they have the new symptoms of the previous slide, and they all jump up and have these acute symptoms. So what do you do then? We actually induce a bone marrow, we just wipe the bone marrow clean, right? So you wipe the bone marrow clean, and then you kind of start from scratch, and hopefully that works. And the therapies for this are really, it's going to be over 2 to 3 years. It's not like other cancers where you just get like 21 days and you might be cured. This is like a whole 2 to 3 year ordeal. Okay, and they might have to they wipe the bone marrow clean, and they're going to be started on some agents to boost the bone marrow. They're colony stimulating factors. They are medications that will stimulate neutrophil production. Filgrastim and the PO filgrastim. All right, those are long-acting ones that will stimulate the production of white blood cells, right? And then they might have to be on chemo for like a while to make sure that they stay in remission. Okay, so the other option is to wipe the bone marrow absolutely clean, and you might be able to get some of your own stem cells before that happens, and they'll wash them away, and they'll clean out all the excess non-functional white blood cells, and they'll give it back to you. That's called an autologous stem cell transplant. Or you might need to find someone that matches, right? So a bone marrow transplant, back in the old days, you had to inject it into your hip, right? You took it out of someone else's hip and you put it back in your hip. But now you can just give it IV, right? And it's going to find its spot. It's going to find its way to your bone marrow, right? So you draw all the blood. It's an autologous one where you take your own blood and it gets treated, right? And then you wipe out your whole immune system. Here's your radiation scan, and they just blast it with radiation. They do total body irradiation. It's called TBI. Thought I had it on here somewhere, but total body irradiation. And that's going to completely wipe out the bone marrow. We're going to give chemotherapy. We've got really, it's called myeloablative chemotherapy. It's going to absolutely destroy your whole bone marrow, right? So you're basically starting from absolute scratch. And then we might give some, neutrophil stimulating factors, but usually after about 3 weeks or so, then we can give a treated stem cells to the patient, and they can hopefully recover and be in remission. There's no official cure to this. It might resurface.
Happy birthday to you.
How are you? 2 years ago, I got stem cell transplant.
From who?
From a 26-year-old kid in Baltimore, Maryland.
Really?
Yep.
Huh.
He's the only reason I'm here today.
Very nice.
Yup.
We're from Baltimore.
Yup.
Yeah.
Yep.
Very cool.
Yup.
What was his name?
His name was Mike Driscoll.
Mike Driscoll.
You? Oh, God.
So it has a really high mortality, but when it works, you can have a functional life. All right, complications of leukemia. So infection obviously is a huge risk factor, so we want to make sure we're preventing that at all costs. So it can be absolutely fatal to someone who has all these non-functional white blood cells. So that being said, if someone comes in with low white blood cells that has leukemia, or just in general, someone has a really low white blood cell, remember 4 to 12K is a normal white blood cell count. If you're less than 1,000, you're really high risk of having an infection. We technically measure what's called the ANC, the absolute neutrophil count. Remember, never let monkeys eat bananas, right? Never was 60%, right? So 60% of 1,000 is 600. So really, if you start getting that white count, you're getting 0.8, 0.4, you're definitely at high risk for an infection. So when they have neutropenia and they have a fever, that's just like sickle cell disease. An infection is equal to almost a death sentence. The same thing when someone has a fever and they have no white blood cells or no functional white blood cells. So that's where we have to give prophylactic medications. So the prophylaxis we give are these guys here. We mentioned these with antibiotics, with abdominal sepsis and just going to the ICU. We give azoles and we give echinocandins. And these guys are usually our go-to medications that we use. The one that has the most side effects is which one? The azoles. The azoles are azoles to the liver and the kidneys. They cause liver kidney damage, right? And then amphotericin B used to be used a lot. It's like the top shelf. It's going to eliminate everything, but it's actually the worst thing we could give to the patient. It really damages their kidneys and liver for that matter. So really, these echinocandins are really where it's at. They have very minimal side effects. Kind of like nystatin has no side effects. Nystatin actually is kind of like daptomycin. It just attaches to the cell membrane of the fungus, and it pokes little holes in it, and it makes it bleed, right? So if someone's neutropenic, we have to do neutropenic precautions. And neutropenic precautions sounds like a SATA also, right? So we have different things we would recommend and teach to someone, like what shows that they understand teaching, right? So can they have flowers? No flowers. Can they have pets? No pets. I'm sorry, Fido, we got to put you down. No. They have to be careful around pets, especially when not sick, right? Either one, right? Can they have kids? Nope. Can they have stuffy noses? No. Can they be around sick people? No. Can they use rectal thermometers? No. All right. So these are all things we would avoid, right? Hand washing. If they are in the hospital, they usually have a private room, right? Everyone has to wear a mask. So that's the goal there, right? You know what the provider said, the other provider, when they couldn't find his rectal thermometer? Some azole has my thermometer.